Start class without them.
Well, Allison is going to be a little late because her dog is throwing up, and I had her bring the dog to my house. Allison lives an hour away from here. Yeah, so I told her to bring her dog to my house, so she didn't have the dog in the car for 3 hours. So, no, it's just because she had to bring him to the vet, and she didn't have time to go drop the dog off at home and then come.
Started! Let's get started. So we're picking up with physiology of circulation. So we talked about the pumps. We talked about the tubes. Now let's talk about how blood flows through those tubes. So arteries and veins. This diagram is a nice representation of pressure in the system. I keep saying pressure in the system. Everybody understands what I mean by that, right? Okay. So where's the highest pressure in the system, in the cardiovascular system? Highest pressure. No, where is the highest pressure in the system? When we talk about, we're talking arteries and veins. In the aorta, exactly. That large artery that leaves the heart. So the pressure is created by what? That ventricular contraction being pushed out into the system. Okay? So the system begins with the artery. Again, this is the arteries and veins chapter. The highest pressure is in the aorta. Why do we see this fluctuation in those large arteries that leave the heart right away in pressure? Well, we have a push, and then we have a... So the push, highest pressure in the system. Systole is the highest point or peak. What is the highest peak on this graph? What is it? 120 what? Yeah, it's measured in millimeters of mercury. And what's the lowest peak? And I'm talking about the peaks in the arteries. What's the lowest? About 80 millimeters of mercury. Boy, those numbers sound familiar, don't they? 120 over 80. Where have you heard that before? That's the average normal systolic and diastolic blood pressure, right? And we see what it's equal to. So when the ventricles contract, that's the highest pressure in the system. Give me another name for ventricular contraction. Systolic pressure. When the ventricles relax, that's the lowest pressure in the system. What's another name for that? Diastolic, distally. Okay? So 120 over 80 is the average. And that's what we can measure. So can we measure blood pressure in the veins? No, because we start not to see that fluctuation or change. So when we measure blood pressure, the pressure in the system, systolic over diastolic, it has to be measured in an artery. In a larger artery, right? So we can see the flux. Brachial.
Brachial.
Yep. Okay, so arteries, once we start getting into arterioles, we can't see the flux anymore. We can't feel the flux anymore. Capillaries, as you can see, the pressure starts to go down as we get smaller, The lowest pressure in the system is where? Yeah, in the vena cavas. It goes down to 0 by the time it gets into the vena cavas. So why is it that blood even flows then? Yeah, everybody's still pushing from behind. So even the pressure, even though the pressure is that low, we're still getting a push from behind, and that's what keeps us eventually dumping into what? From the vena cavas, where do I dump?
Right atrium.
Into the right atria. Okay? So, some of the different things that are going to affect blood flow, blood pressure in the system are outlined for us under definition or terms. So blood flow through the system is cardiac output, blood flowing through veins and arteries, being pumped by the heart. That's flow through the system. Don't forget, we have to also flow through organs. So we might make a slower stop at the kidneys, or we might make a slower stop in the liver, but we'll eventually flow back to the pump and continue to flow through the system. So when we talk about blood pressure, we're talking about the pressure that's exerted from the pump and the pressure that those tubes, arteries, and veins are withstanding. Resistance, we said a little bit about that last class just before we left, but resistance has to do with how smooth and how wide or thin the tubes actually are. If I have a, yes, that's called resistance. So if I have a tube that's nice and smooth, the resistance, the movement of fluid through it, is going to be lower than if I have a, remember we talked about sandpaper? Oh, so if the tubes were atherosclerosis. So resistance, peripheral resistance, refers to that term. Now, what are some of the things that can affect blood flow? Blood viscosity. What's viscosity? How thick it is. So remember when we talked about blood, we said 55% of blood was plasma, 45% was formed elements, right? What if I have too many red blood cells? What if, yeah, it's going to be thicker. Is that going to have any effect on resistance?
Yeah, it's going to be harder.
Exactly, because it's going to be harder to push through those tubes. The length of blood vessels can also have an effect on resistance. The more I have, the more resistance I have to undergo to move.
Do you mean if person is high, have a high height?
Height would increase, but also your just body mass in general. So if you increase your body mass by any adipose tissue or muscle mass, you're going to increase the length of your blood vessels because you have more tissue to feed. Okay? Blood vessel diameter, and we already talked about that when we talked about my little hose demonstration, right? The smaller the diameter, the more what? Well, even if the pressure stays the same, the resistance is going to be increased, right? Versus a wider blood vessel. So relationship between flow, pressure, and resistance. Am I going to make you understand that problem? Am I going to make you use that with your calculator? Yeah, no. So don't worry about that blood flow versus change in pressure and resistance. Don't worry about that. Systemic pressure. Pressure in the system is what the book talks about next. So arterial blood pressure results from the wave in pressure that we get from the heart. And that's what we feel when we measure blood pressure in the system. So we're looking at contraction versus relaxation pressure, or systole versus diastole. So they talk a little bit about those terms again. When I take my pulse, what is that? What does that represent? It is very closely related to the cardiac cycle. It's very closely related to what?
It's
Well, the pressure reading.
Isn't it just basically like every time that your heart?
Exactly. Every time that ventricle does what?
Closed.
Every time that ventricle contracts and pushes the volume out, stroke volume, you are feeling that pressure wave. It's not as strong as the beginning pressure wave when the heart actually pumps that out. So here's another calculation you need to know. It's called pulse pressure. And what's pulse pressure?
Pulse pressure is diastole.
Systole,
So it's diastole pressure.
systole minus diastole. Yes? Systolic minus diastolic is the pulse pressure. Because it's not as strong as what's coming right from the heart. So you're ahead of the game. So systolic minus diastolic is pulse pressure. And that's in millimeters of mercury, what you feel when you feel your pulse. Pulses are easier to feel in more superficial arteries. Can you feel a pulse in a vein? No, because there's no difference anymore. So you can't feel that wave anymore. So that's another thing we have to remember for our calculations. Because the aortic pressure fluctuates up and down for each heartbeat, and I'm reading this right from the book, the important pressure figure to consider is the mean arterial pressure. That's a little bit different in the calculation because we have to take into consideration pulse pressure, diastolic pressure. So there's another calculation you need to know. The mean arterial pressure, and you can see this at the bottom of page 703, is the diastolic pressure plus the pulse pressure divided by 3. Remember, you have to figure out pulse pressure, right? Because in your patient chart, all you're going to have is what? Systolic over diastolic. That's all I'm going to give you. So if I ask you to calculate the mean arterial pressure, you have to also know how to calculate what? Pulse pressure. Okay? And they give us an example here of an average.
Blood overcome to come to the tissues?
Well, it's the pressure that we feel in the mean arterial pressure to get to the tissues, yes. Okay? So those are more calculations to add to the calculation list. Who do we have on there so far? We have cardiac output. We have what? A MAP, mean arterial pressure, and we have pulse pressure. Yes?
So this is the mean arterial pressure. Is it pressure in the arteries?
It's the mean arterial pressure. The mean pressure, do you know what the mean means? When you do math, do you know what a mean is? Okay, so it's kind of the average. It's not an average like take everything and divide it by how many times you did it, but it's in that range. So like your class average, your test average, it's the average.
But it's not in all arteries, right?
Yes. So it's the mean of what we have in the arterial system.
Yeah, but we saw the diagram.
Correct, in the arteries that we can measure pressure in.
So this is what I need to know.
Correct.
It's not all arteries. It's not the pressure in all arteries.
It's we can't measure pressure in all arteries.
Where we can.
Where we can. And again, it's the mean. And you can see on that diagram, you'll see that line that sort of runs through there as well. Okay, so what happens to capillary pressure? Starts to go way, way down. It's not the lowest in the system, but it's pretty low. We can't measure a change or a flux anymore. And why does it have to be low in the capillary beds?
Because it has to be exchange of
No,
nutrition.
exactly. It helps to slow things down a bit so that exchange of nutrients and gases can happen in the capillary beds. So it's not at 0, but it starts to get way lower than it is in the arteries. And then once we hit the veins, well, it's way, way low. We're down to the bottom. So how does everything get back up to the heart? especially, say, from the lower extremities. And I think we already discussed this in the last class, right? Yeah, muscles. So muscle contraction, pushing on those tubes, is also going to help blood get back to the heart. They talk about this on page 704 in your textbook when they discuss things like the muscular pump. So muscles will push on veins to help push blood back to the heart. Some of the muscles, some of the major muscles that help push on major tubes in your body, major veins that start to get larger and larger to dump back into the heart, are in your thoracic cavity, your respiratory pump. Do we have a big issue with stuff up here?
No, because
Gravity's helping me there, right? So that's not a big, huge issue. It's everything that's lower, basically, than your heart. So thoracic cavity, especially the lower extremities. So, again, we talked about this. Sympathetic venoconstriction, sympathetic nervous system, will actually help by causing some contractions to happen to help blood get back from the venous system. Some smooth, some striated muscles as well. So that's how blood gets back. Maintaining blood pressure. Who's responsible for monitoring blood pressure in the system? Who's responsible for a lot of stuff? Exactly, your central nervous system. So this diagram shows us some of the factors that are going to enhance cardiac output when necessary. When I exercise, what do I have to do? Yeah, pump up the heartbeat, increase heart rate so I can increase oxygen distribution through the body. So I have to increasing activity is not only going to increase cardiac, but also what? Respiratory as well. Who's going to help me with that? The brain. But what division of the peripheral nervous system is going to help me? The autonomic, which sympathetic? Yes? So sympathetic venoconstriction will increase. You see that right in the chart there. That's going to help increase venous return and get blood flow through the body in a quicker rate. There's a lot of repetitive information in this chapter. You see that? So we see, again, terms like end diastolic volume increasing. Sympathetic versus parasympathetic, what's the difference? Exactly. So we see in this diagram here that sympathetic versus parasympathetic increase versus decrease. We want to increase heart rate to increase cardiac output. So they also include some of the hormones as well. Epinephrine increasing in the blood can also increase what? Stroke volume, and that's going to help increase cardiac output as well. Yep.
So you said we don't have to measure or calculate blood flow and
Nope.
or because there's a maintaining blood pressure.
Yep, we don't have to do that. Nope. So understand short-term regulation neuronal controls. Understand that the central nervous system is responsible for helping to control heart rate, which in turn helps to control blood pressure. We also have several different places throughout the body that are going to monitor pressure, including the heart, including some of the major vessels that are under pressure. So some of those beginning elastic arteries are going to have groups of cells that are going to help monitor pressure in the system. These groups of cells are called baroreceptors, or pressure receptors. In this diagram, we can see some of those little baroreceptors down there in the carotid sinuses. And those guys, the carotids, are feeding who? Yeah, the upper regions in the central nervous system, the brain. So when the pressure starts to fluctuate, these guys are going to help by sending messages, sympathetic, parasympathetic, depending on where we're going with pressure, to maintain homeostatic balance in the pressure system. So we see another one of our very familiar negative feedback loops We see what happens when blood pressure increases. What do we have to do to blood pressure when blood pressure increases? Yeah, we have to lower it, exactly. So how are we going to lower pressure in the system?
Send the signals to
Think about our resistance.
far.
If I can dilate blood vessels, I can make them larger, relax. Can I decrease resistance in the system? Okay. So some of the signals that I'm going to get that will be sent to me via the central nervous system are going to do things like lower my heart rate, are going to do things like decrease contractility, and that will then therefore decrease cardiac output. If I decrease cardiac output, I help to decrease pressure in the system. Yes? So I sort of decrease the sympathetic messages that I'm getting. And I'm kicking in with my who? Who's the opposite of sympathetic? Parasympathetic. So what happens when the blood pressure goes too low? That's a problem too, because if the pressure goes too low, abnormally low, I'm not doing what?
Enough oxygen to the tissue.
You're not getting enough blood to the tissues. You're not getting enough oxygen to the tissues. You're building up waste products in the tissues. So the bottom part of the diagram are messages that are going to help increase pressure in the system. So I'm going to do the opposite. What am I going to do to blood vessels to increase resistance? I'm going to constrict blood vessels. Increase resistance, increase pressure in the system. That's also going to increase contractility, and because of all that, we're going to increase cardiac output. Yes? Yes. So understand those relationships in that diagram. Some of the hormones listed here on table 19.2 show us the effects on blood pressure. So things like epinephrine will help increase blood pressure. Angiotensin II, we're going to talk about that guy when we talk about the renal system, can help increase pressure. What did angiotensin do that might help increase pressure in the system? This is, what else?
Activation of another.
Well, don't read from that. Don't read from the chart. I want you to think back. Angiotensin, renin. What did those guys have to do?
I want to say, but I didn't read anything.
Okay, what?
Knew that.
So, what else besides vasoconstriction, vasodilation? What else did those guys have a play in?
It will activate hormone, which is antidiuretic hormone, that will help retain water.
Correct. If I bring more water into the system, what's that going to do to pressure in the system? It's going to increase. Do you see why? Because I'm bringing more volume in. Okay? So the kidneys also are going to play a role in helping to regulate blood pressure in the system. ANP, what's that? Not ANP. ANP. That's from the what?
Heart,
Yeah, the heart makes it. So there's some baroreceptors. They're helping to monitor pressure. When pressure goes up in the system, those guys are going to signal the release to help do what? Yeah, bring pressure down. So we're going to see some different players also working to help bring down pressure in the system. Vasoconstriction, vasodilation in this case to decrease pressure, and then of course a secondary effect on the kidneys as well. So antidiuretic hormone, that's going to help bring what? More what into the system? More water into the system, therefore it's going to help to do what to pressure? Increase pressure. Aldosterone. And that's going to have its effects on those kidneys again. Yes? So, yes, you need to know the basic effects of all of these hormones on blood pressure.
it was my question.
Oh, okay, I just told you that's what you need to know. Question?
My question, do we need to know the process of that regulation?
Everything from that chart.
No, not from that chart. There is another.
Yeah, those are the details. So in the chart, if you look at the chart, you see the variables, you see what it causes and why it increases pressure. Okay, so just what we just went through in our discussion, I want you to know that for this. Okay? So,
I'm talking about this one.
yeah, we'll talk about that next. So, chemoreceptors and reflexes, chemical receptors, influences on higher brain centers. A lot of these guys are involved in signaling those different responses. We also have short-term regulation, hormonal controls of pressure in the system. The adrenal medulla and some of the hormones we discussed earlier in the endocrine system, epinephrine, norepinephrine, angiotensin, atrial natriuretic peptide, ADH. In this diagram here, direct and indirect, guess what you're going to see? More repetitive stuff. So they'll talk about the hormones that we just discussed. If we want to decrease pressure in the system, basically what we want to do is decrease resistance and decrease volume. So think of all the things involved in decreasing resistance and decreasing volume. So the initial stimulus in this diagram is what? Yeah, pressure. In this case, what happened to arterial pressure? It's going down. So what do we have to do? We have to pick it up. And again, I'm not going to go through it because I'm just going to be repeating myself again. But think about what we have to do to bring it up. We have to increase volume and we have to increase resistance, which will help increase pressure in the system. So we see again a repeat of some of the players that we just talked about in our discussion. Some of the factors that are going to increase our mean arterial pressure are discussed in this diagram here. So different things like the muscular pump, release of some of the hormones, any changes to the volume. So when we decrease volume and decrease pressure, we decrease fluid and we decrease what? Resistance. Again, a lot of these are very repetitive. Sometimes it's nice to see all of them in different ways because after you go through them a few times, hopefully the light will go on. So I like to not ignore them, hopefully. But that's kind of the bottom line. If I want to increase resistance and increase volume, I increase pressure. If I decrease resistance, I decrease volume, I decrease pressure. So we can do it in multiple ways, and that's what these diagrams are introducing to us. So, that pulse wave, and they talk about direct renal mechanisms and indirect renal mechanisms. Should you understand that? Yes, you should. Again, in the basic way that I described. Taking a pulse. When I take a pulse, and you'll do this in lab after your lab test. You have a lab test today? After your lab test next week, you'll start doing some labs. Oh yeah, 2 weeks, that's right. You'll start doing some blood pressure readings and pulse readings. Now, hopefully you won't do all of these because some of these are a little personal and we probably won't be wanting to do that in lab. But what's the best place for us to feel that pulse wave? Any place that has an artery that is more towards where? More toward, not necessarily towards the heart, because this one's a real good one, isn't it? And this one's really hard. Surface. So when we start to get those arteries that tend to be closer to the surface and then tend to run across something that is stiff, we can feel a nice pulse wave. You're going to see and try to determine that pulse wave in class, and we call that palpating the pulse, and you'll do that in lab class. And you'll see that one of the harder ones to feel, even though it's much closer to the heart than this one. What's this one? The radial pulse. It's much harder to feel because it is not as close to the surface. The artery tends to run deeper.
Are you talking about the facial?
The facial pulse, yeah.
Do you know where respiratory therapists usually they would draw blood? This is the easiest way. It's the easiest artery.
Respiratory therapists,
Yeah.
usually in the
They
wrist
draw blood from arteries.
or femoral.
The femoral is the best one.
Yeah, because it's the
It
large.
is
It's the largest one.
Yeah.
Well, and the largest one that's close to the
Because
surface.
they checking blood for oxygen.
Correct.
And they have to take it.
The gases. Usually a doctor draws blood gases. Femoral is usually, especially when patients are compromised, it's much easier to get it from the femoral artery. So it depends. It depends on what your patient's going through. The respiratory therapist doesn't do it, no. It'll be the, right, and they do it in the arm. But, we're talking about patients that are in ICU, or in my day, now it's CCU, critical care unit. We used to have 3 different units. SCU. But patients who are in critical condition, usually it's much easier to get it from femoral, and the respiratory therapist doesn't do that.
But they do it. My husband does it all the time, and he works at St. Mary's for...
Great. So he's able to do it at St. Mary's. That's good.
No, it's because I know.
Yeah, no.
Because
I know. So yeah, you'll feel your pulses in appropriate places. And again, that's one of the keys. So close to the surface, running across a hard surface. Measuring blood pressure. You're also going to do this as well. How many people know how to take a blood pressure? Okay. This is your best friend. Let me just show you quickly. And I hope I don't screw up my recording doing it.
Manual or automated?
Manual.
Big difference.
Yeah. Automated, that's all fine and good, but you have to understand the principle of it, so it's always good to learn how to do it manually. You guys have a wonderful program. It's called Mastering. It's their best friend this semester, isn't it?
I've been extremely busy this morning, though, because it was going so slow.
Was it going slow? Oh, don't tell me that.
Mine was freezing up last night when I was on the pad.
Really?
I was like trying on the histology, I was looking at the slides and I was like, oh my god.
So if you haven't used it yet, and I can't imagine that any of you haven't used it yet, if you haven't, you should. I want you to go and use this one. Before you come to lab in 2 weeks.
Blood pressure is an important indicator of cardiovascular health. It is influenced by the contractile activities of the heart and conditions and activities of blood vessels.
So I can go through it, but I don't want to waste time. I want you to go through it. Because if you've never taken a blood pressure before, this is awesome because you'll hear what you're supposed to hear. And you understand why you're hearing what you're hearing. Can you hear blood flow through blood vessels? No, you can't. So if I take my stethoscope and I put it even on a nice artery in the arm, I can't hear. Can I? I can't hear anything in the veins at all. You can't hear blood flow. So why is it you can hear something when you take a blood pressure? Exactly. So that's what you're doing when you take a blood pressure reading. You're actually taking an artery in the what region? That brachial region, and you are closing it off. As you close it off, you're going to start to hear. That's the best. That's what you're going to hear, and you'll hear it in this video. As you start to close it off, you'll start to hear it bang up against the sides until it's closed off. Then you'll stop hearing something. At the point in which I close that off, that's very close to the highest pressure in the system. when you start to let off on the pressure, that's what you'll hear. So when you start to hear the sound, that's very close to the highest pressure in the system. That's your what? That's your systolic pressure, the highest reading. When you stop hearing the sound again, that's your diastolic reading. If you've never done it before, the best thing to do is put the blood pressure cuff on, get in the region that you're supposed to be listening at, and start to pump it up. You'll start to close off and hear. You want to hear that. So don't pump it up too high, because what are you going to hear? Nothing. So pump it up until you start to hear that sound. Then you know you're in the right place to listen. Yeah, yeah. And then you will...
They usually say to pump it up to 180.
Yeah, before it's, well, after you know where you're supposed to be. This is the first time you do it. You pump it up to 180, you're closing off.
You mean to just pump it up enough so that you hear it start?
Correct. So you want to pump it up so you can hear that sound. You don't want to pump it too high.
That's so you just know what you're listening to.
Exactly. Well, so you know you're in the right place as well. If you know you're in the right place, then you pump it up to 180, right?
The other thing too is that a lot of blood pressure, cuffs or whatever, when you let it out, it the little pin thing, jiggles at the high.
Yeah. Don't trust the jiggle though, but it is. It's in the right. It's in that area too. Yeah.
You can't trust it completely, but it's usually pretty close.
It's pretty darn close.
Well, you need to have the right size cuff, and then you need to make sure that
Correct.
the person that you're doing, it's hard to hear on different people because of, whether they're older or if they're bigger.
Exactly. And that's why when you're starting to do this for the first time, that's a little trick. So you want to be in the, because sometimes you'll watch people in the lab and they have the stethoscope way over here. It's like you're not going to hear anything no matter what. So this way you get the sound going, you'll make sure you're in the right place, and then you pump it up to close it off. Remember, you're closing off arteries in someone's arm. So you don't want to keep the cuff on there too long while you're fumbling with your stethoscope trying to figure out where you're supposed to be listening, because your poor lab partner will not like you very much. So distribution of blood flow at rest and during strenuous activity. We see that blood flow to different areas, depending on what we're doing, changes. So when we are looking at rest, we see a nice even distribution of blood flow. What happens when I start strenuous activity? What happens to that distribution of blood flow? And it makes sense. You're going to start getting more blood to where? Skeletal muscle increases a great deal, right? Because I need nutrients and I have to get rid of waste from muscle that is exercising. What is the velocity of blood flow diagram? What's that showing me? Well, where's blood flow fastest? The arteries, right? So we see the fastest velocity of blood flow, in the arteries. Where is it actually moving the slowest? It's moving slowest through the capillary beds. What's the greatest total area? In the capillaries as well. So when we see that the area increases a great deal, the speed is going to come way down. That makes sense, because what do I have to do in the capillary beds? It's exchange place. I want to go as slow as I possibly can so I can exchange wastes and nutrients in the circulatory system. There's metabolic controls that can help regulate local flow. Auto-regulation is what is discussed in your textbook. Metabolic controls are going to help control blood flow, help control velocity. Things like pH in the system is going to have an effect on things like your cardiovascular system and respiratory system. When we discuss the when we discuss the respiratory system, we'll see how respiratory gases have an effect on blood pH. If I have too much carbon dioxide in the system, I'm going to change the pH of my blood. Too much carbon dioxide in the system will cause me to make more acid in the system. Not enough carbon dioxide in the system, even though it's a waste product, there has to be a fine balance, can cause problems with blood pH as well. What's blood pH supposed to be?
7.35 to 7.45.
Exactly, 7.35 to 7.45. So the book talks about some of the different controls we see in this diagram, intrinsic and extrinsic controls of arterial smooth muscle in systemic circulation. So again, we revisit some of the hormones that we already discussed in the endocrine system and that are discussed in those very repetitive diagrams that we saw a couple of moments ago. Things like atrial natriuretic peptide, angiotensin, antidiuretic hormone, epinephrine, norepinephrine, and what their effects on the cardiovascular system are. Brain. How much blood do we get to the brain? It's kind of big in the volume area, about 750 milliliters of a total volume per minute. If you go back to that diagram with the guy in the basketball, we see that even though blood changes, blood distribution changes with exercise, does it ever change to the brain? No. Because why do you think that's true?
Too much pressure?
Well, not even too much pressure, but do we ever want to disrupt the exchange of nutrients and wastes in the brain? We always want to make sure that the brain is getting oxygen, getting rid of carbon dioxide, getting nutrients, and getting rid of wastes. So that's not ever going to change. Whereas it changes in the lungs and heart and skeletal muscle during exercise. Blood flow through capillaries and capillary dynamics. So we see that in the capillary beds, we have to have exchange of nutrients and wastes. There's a couple of factors that are going to drive that exchange. Pressure is going to drive that exchange. Where do things want to go with respect to pressure? To lower pressure, exactly. And the way I always remember this is, do you want to be under high pressure or do you want to be under low pressure? Do you want to study for 17 exams and do 3 jobs, or do you want to sit on the beach in the Bahamas with a pina colada? I'm going for the pina colada every time, right? Pressure. And hermits, exactly. That would be ideal. Pina coladas and hermits. Makes me feel better already. So, molecules want to go from a high pressure to a low pressure as well. So pressure is going to drive a lot of the movement we see in the capillary beds. So they talk about fluid movement and bulk flow, and we've talked about these things before last semester when we talked about osmosis and diffusion and the movement of molecules. Now let's just apply those principles we learned to pressure and pressure gradients. So concentration gradients are going to drive things as well, but when we talk about pressure in the system, they're going to drive movement in the capillary beds. So they talk a little bit about hydrostatic pressure. Hydrostatic, what's that? Yes, exactly. So remember, the quickest way for me to alter pressure in the system is to do what? Exactly, add water or take it away. So another thing that's going to drive pressure and pressure gradients and pressure differences in the system is the colloid osmotic pressure. How much stuff I have dissolved in my blood plasma. Hydrostatic osmotic pressure interactions. The two of them are going to work together to help drive movement of molecules from one side to the other, from the blood into the tissues, from the tissues into the blood. Yep.
What do we need to know for blood flow to the lungs, to the heart?
You don't have to memorize the numbers. You do have to understand that there are differences depending on whether you're at rest or whether you are in exercise. And you do have to understand that between the two different scenarios, the brain is still going to get its fair share. So that doesn't change.
So, I mean, about blood flow, there's just a line to, like in our PowerPoint, there's a line to like pulmonary circuit, so pathway is short, and others more like a veins and venules. So do we know all the...
You don't have to memorize the notes. Just go back and listen to the lecture. So what we talked about in lecture is what you should know.
No, I was here, I was listening to you.
Well, good.
Double check.
Yeah, well, that's, I told you during lecture what I'd like you to know about all those things. So, no, you can go back and listen to the lecture. So, exchange in the system is driven by these factors. And this, I don't know what happened to this poor diagram. It got all messed up there. But when I start to change things like hydrostatic pressure, osmotic pressure, I'm going to change exchange in the system. This, again, is a lot of review stuff that we learned way back when we talked about osmosis and diffusion in the system. Hydrostatic pressure versus osmotic pressure. Review in your brain the principles of tonicity. Remember those? Isotonic, hypotonic, hypertonic. Okay, and that's basically what this is reviewing. Osmosis is the movement of what? Water through the system. So these are some of the different factors, and if we look at that, it's better if you look in your book on page 719 in the textbook, you can see the larger versus smaller arrows. So hydrostatic pressure in the capillaries is going to help push fluid out of the capillaries. Remember, I talked a little bit last time in class about the fact that too much water moves out of the capillary beds, right? Who is going to help me pick up the slack after we finish this chapter? What's the next chapter?
The lymphatic system.
Yeah, the lymphatic system. So we have a great deal of pressure that's going to help bring water out of the system out into the capillary beds. We have osmotic pressure that's going to help to equalize that. But you notice the arrows are different sizes, right? There's more being pushed out, more fluid being pushed out than is being pushed back in. So again, that extra fluid is going to be taken up by the lymphatic system so we can help equalize fluid balance inside and out of the circulatory system. So these are some of the factors that are going to help reabsorb nutrients and wastes and water back into the system. So again, what I want you to know is, or have a basic understanding of, is some of the different factors that affect exchange in the capillary beds. This is a nice diagram because it's a nice visual for us. And we see that hydrostatic pressure and osmotic pressure play a role in gas and fluid exchange. Okay? Ooh. And that's all in that same diagram. All right, so circulatory pathways, blood vessels of the body is what the book starts to talk about next. Guess what? We're not going through that. We're done.
Circulatory shock.
No, we're going to talk about that. I want to talk about that. But as far as the next diagram,
Pathways and developmental aspects, you don't want to that.
we're not going to go into the specific pathways, and we're not going to go into the developmental aspects. So yes, you are correct. I do want you to note that when I lose too much volume, I can have a problem creating these pressure differences. And that's what they talk about when they talk about circulatory shock. They talk about hypovolemic shock. And that, at this point, I'm hoping that's pretty self-explanatory, right? What's exactly. So if I decrease the volume, I decrease the pressure. If I decrease the pressure too much in the system, is this going to happen? No. Not enough pressure in the system. Remember, I want to go from a high pressure to a low pressure. If I lower the pressure in the system way down, is exchange going to happen? No. So these discussions about volume and shock are all pretty much the same discussion. Anytime I mess up that pressure gradient, I'm going to mess up exchange in the system. So we can have vascular shock, we can have cardiogenic shock, we can have hypovolemic shock. All of these, in some way, shape, or form, are disrupting pressure gradients in the system. Okay, and again, general definition. So some are caused by chemicals, some are caused by neurological effects, and some are caused simply by losing too much volume in the circulatory system. In this diagram here, this poor fellow, bless his heart, we used to have a little gash in the finger. Now I guess we're giving people a really big gash in the stomach. But what is happening to this poor individual in this diagram? He's losing blood. So he has acute bleeding, a big loss of volume in the system. And these are all the things that go crazy to try and regulate back the volume difference, the pressure differences in the system. Unfortunately, some of them are actually causing more harm than they are good. So, chemoreceptors, decrease in blood pH, baroreceptors, pressure receptors, they're all going to kick in at once to try and fix the problem. Hence the shock part. You know, when everybody's trying to go crazy to try and fix something, and they cause more harm than they do good. That's basically what's happening in a shock situation. So the hypothalamus is going to be activated. Baroreceptors are going to go crazy. Chemoreceptors are going to go crazy. The respiratory centers are going to try and kick in. So what happens to somebody that is starting to go into shock? Has anybody ever dealt with a patient? Okay, what are some of the symptoms? They start to breathe very, very quickly. And sometimes they'll almost hyperventilate. That's kind of near the end when everything starts shutting down, right? We'll start to see them get cold. We'll start to see them get clammy. So this diagram, and again, you don't have to memorize a diagram, but it's a nice one because it ties in all of the different players trying to regulate pressure in the system.
Is that why when you have an injury like that, you don't really feel it right away sometimes because all that stuff is overactive, so you can't really feel the pain?
Well, sometimes you stop feeling the pain, and sometimes you don't feel the pain just because of the way the injury took place. Like, I'm going to give you my bonehead move of my life. Don't ever talk to your mother on the phone while you have a knife that is very, very sharp, and you're making dinner. So I was talking to my mother on the phone, and I didn't have a knife to cut my vacuum-sealed bag, so I took my very sharp knife that my son had just sharpened for me, thank you very much, and I went to open my vacuum-sealed bag. Well, I thought I nicked my finger. So I said, oh, Ma, I got to call you back. Hang up. It didn't hurt. When I looked down, I had cut the whole tip of my finger off. It was in the sink. But why didn't it hurt? Because of the way the injury took place. So it didn't hurt. I didn't have any pain because the knife was really, really sharp. So, and then your question about the shock thing, because this is going on, sometimes pain is sort of secondary on your mind.
So did you put it back on or what?
Is what?
Did you stitch your finger?
No, I brought it. Thank goodness my son was there. So I grabbed a baggie and I brought it with me, and she kind of looked at it and went, ha ha, and threw it away. No, I had to get some weird little, there's this like foam substance. Have you ever seen it?
Oh, yeah. Was it like a...
It's a surgical foam. It's so cool.
My friend Rich did the same exact thing, except instead of trying to open a bag, he somehow had the great idea of taking a nail out of the wall with his pocket knife. Didn't work out.
Yeah, don't do that. So now I have a scar on the tip of my finger.
They use one of those, it's called like a wet dressing, right?
Yeah, it looked like foam to me. It looked like a styrofoam cup. That's what it looked like. And what they did was they squeezed it. It was white. And they squeezed it on the end, and it kind of fused almost, so that it blocked the hole, and then it allowed my skin to grow up underneath. But yeah, that was not fun.
Do you know those mandolin cutters?
Oh, those are nasty, nasty, horrible things.
That came in that cut her thumb with one, and we had to send her to the ER, but it was funny.
instrument. A
Really
cooking instrument.
Wrong kind of mandolin.
Okay, so the rest of the chapter we're not going to cover, okay? The rest of the chapter is going to go specific into all the different branches that we're going to see in the cardiovascular system, this stuff. We're not going to do that in lecture. That's for Carmen to do. But I want to point out to you, there's two diagrams that you're going to see again. I think it's actually one. You're going to see this one, and that's on page 725. And I think he just does veins and not, yeah. And then there's one for the veins as well. And that's on page 737. I think, if memory serves me, I think it's just the arteries that you're going to do. Yeah. So it's just the diagram for the arteries.
Can I ask you, I don't know if you mentioned that there's a homeostatic imbalance, hypertension.
Yep. So high pressure.
Details would
Yep, you should know about those. Nope. Basic definition, and it has to do with pressure in the system. So hypertension versus hypotension, you should know the difference between them. So yes, know that from your outline. Oop. All right, my friends.
Are we really your friends?
I am.
That's funny. Maria.
Yeah, I'm still here. Keep going. I'm just getting the next one up.
I totally forgot. Are you gonna do?
You send me in. Yeah, it was. Oh,
It was over at 12:25.
Yeah.
I almost forgot until Allison remembered last night.
I'll open it again.
for blood vessels, when would you,
Don't worry about it. That's Carmen.
when would you place the
Oh, I'll open it up today.
and to what time?
You'll be due
Tuesdays
as usual.
12:25.
Yep, 12 Tuesday at 12:25.
Will you let us a little bit, 19? Will you let us leave a little bit early because we have to prepare for exam?
No. You should already be prepared for your exam.
No, I mean just taking,
No. Well, you can go to the bathroom before your exam. I don't think Carmen's going to make you go in there and immediately start your lab exam. So, chapter 20.
Are you gonna do the pressure questions for the last chapter?
We're kind of behind. So, I love you all, but we got to move it. 19 quiz will open up today, and then, the usual. It'll be due before class on Tuesday. Yep. Okay, this one's a quickie. We might even finish it today.
You're lying, right?
I'm not lying. So, we just talked about the venous system, right? We just talked about the capillary beds. We just talked about hydrostatic pressure pushing out what? Too much fluid into the capillary beds, right? Well, we also mentioned this guy, the lymphatic system. The lymphatic system is a series of tubes very similar to the venous system. As a matter of fact, if I look at them under the microscope, I'm going to have a real hard time telling the difference. So, when we looked at the capillary beds, we just saw this picture before. We saw our arteries, veins, true capillaries. We saw that water was being pushed out along with everything else. And then we see how the lymphatic system intertwines into the capillary beds. The lymphatic system different than the circulatory system because it's not a continuous loop. Okay, the lymphatic system has a beginning and the lymphatic system has an end. The tubes themselves are a little bit different because what we're going to see in the lymphatic system is there's little flaps in those tubes. Now that's going to allow for more substances to move in. More substances like what? That excess fluid. Because of the pressure that's been set up in the capillary beds through what we just discussed in the circulatory system, that pressure is going to help push that excess fluid into the lymphatic system and through those little flaps. When we discuss the digestive system, we're going to see that the lymphatic system is going to play a large role in absorbing nutrients, especially lipids, from the small intestines into the circulatory system as well. And it's because of the design of the lymphatic vessels, because of those little flaps. So in this diagram, we see those nice green tubes. They're no longer red and blue, but the lymphatic system is denoted in your textbook with those little green tubes. So a series of tubes that I would have a hard time knowing the difference between an artery and a vein. So what are they made of? They are made of endothelial cells, very similar to what we saw in the venous system. We also have a wrapping on the outside, very similar to what we saw in the venous system. Because the pressure, is there a pump in the lymphatic system? There's no heart there, right? What's the pressure that's going to help move that muscular pump? The same pump we saw helping blood move back to the heart in the venous system, we're going to see help move fluid through the lymphatic system. The fluid's final destination is going to be back where? Back to the circulatory system. Okay? But there's a lot of places in between that it's going to stop. So when we look at lymphatic capillaries, we see, again, I'll go back, endothelial cells wrapping around the outside. And see these little flaps? They're calling them mini valves. But that's what's going to allow for that excess fluid to be absorbed in the tissues. And when we talk about the small intestine, we're going to talk about a structure called a lacteal. This is part of the lymphatic system that's going to help me absorb lipids into the circulatory system. When we look at the pathway and the series of tubes, we see kind of an uneven distribution of left and right. In this diagram, we see that certain portions of the lymphatic system, those lymphatic vessels, will drain into an area called the right lymphatic duct. And that's on the right side. The left side is where the uneven distribution takes place. So the left side is going to come from both your extremities and most of the left side of the body and dump into the thoracic duct. Both of these are then going to feed into, guess what? And back to the heart. What's that big vein called that feeds back into the right side of the heart? The vena cavas. So both those major vessels are eventually going to feed into the vena cavas and eventually put that volume back into the circulatory system. So that's how we get that excess fluid back into the circulatory system. So you should know the right from the left.
So the thoracic, what drains into the thoracic duct again?
So the thoracic, if you look at the diagram, it's everything in brown. So this, everything from the lower extremities and everything from this side of the body.
Where's the lymphatic duct?
Where's the lymphatic duct? It feeds right into the, if you see up, where is it? It shows up right there. See right there? The jugular trunk? Okay, and see right here? The brachial mediastinal trunk? Those are two main branches of the venous system that will then feed into the what? What do those two branches feed into? I can't point that high. Wish I had a pointer. Yeah, superior vena cava. Yes? So they feed into those two major vessels, which will then dump into the superior vena cava. And that's how that volume of water gets back into the circulatory system. Bless you. Now, if you look at this diagram, we see...
Thoracic duct. It will go to the vena cava as well? Right there in the middle.
See it up there?
No. My question was, is it, will it end up in the vena cava as well?
Look at the diagram. What do you think?
I don't see anything here. So
You don't see the thoracic duct?
No, it's right.
It's right there in the center. It feeds into the See where it says entrance of thoracic duct into vein, left brachio, mediastinal trunk. You see it? And what does that feed into?
It's on the left side.
It dumps in. Look at the blue tubes. They dump into what?
Oh, this is blue.
The superior vena cava.
Both of them are superior.
Correct. So that's how the volume gets back into the circulatory system. What we see is very similar to what we saw in the venous system. We go from capillaries really small and the vessels start to get large. The other thing we have to go through is all of these little lumps of tissue in the lymphatic system. What are those called? Lymph nodes. So those are lymphatic tissues. Lymphatic vessels are very similar to veins, and lumps of these little lymphatic tissues have to be passed through. Anybody ever play pinball? You know what a pinball machine is? You take a little ball, you push it through a bunch of things that go bing, 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 bing. Yes? That's kind of what a lymph node is. So as that fluid travels, it doesn't take a straight shot up these vessels. Part of the lymphatic system is lumps of these tissues where the fluid has to kind of enter in and play pinball before it continues on its way. So as we follow the lymphatic system up back into the circulatory system, we're going to see lumps of this tissue all the way through. Some of them are larger, some of them are smaller. There's an area in the center, right above that abdominopelvic region. And what do I have down there? Lots of. Yeah, lots of intestines, small intestines. Remember I said the lymphatic system was responsible for helping me absorb what? Lipids. So we're going to see that that cisterna chyli is kind of a culmination of a lot of the lymphatic tissue and lymphatic vessels that hang around in the abdominopelvic region. Have any of you seen a commercial lately for Activia? And it says something like 70% of your lymphatic system is in your digestive system. You didn't hear that? I did, because I'm an anatomy teacher. Do you understand why now? Because a lot of the lymphatic system hangs around in that intestinal area. It depends. Sometimes, and again, if you've ever dealt with oncology and some cancer patients, certain cancers tend to travel certain pathways, you know, lung to brain. They have sort of this pathway thing, and it has to do with the lymphatic system. Yes. So. Yeah, and they again, because it's a place for fluids to travel, if cancer cells get into the lymphatic system, then it's difficult to track where they're going to end up, because look at the pathways that they can follow, and they might end up in different tissues depending on where they started. So it's tough when they get into the lymphatic system. So lymphatic system is for transport, but lymphatic system also plays a big role in what you're going to learn in chapter 21. So exciting. Your immune system. Remember all those little places I have to stop off between the tubes, that lymphoid tissue? Well, in the lymphoid tissue, we're going to find lymphoid cells. Now, lymphoid tissue can be as simple as a lymph node, or it can be larger lymphoid tissue, like tonsils. Huh? Don't have those anymore? See, in my day, they used to rip those out really quickly.
It took them until I was
Yeah, in your age, they typically don't do it unless they're causing lots of problems. Too many strep infections, that is usually the issue. When I was a kid, they used to, they'd get swollen and they'd be like, rip their tonsils out. Now we realize the tonsils are extremely important because they're your first line of defense for anything you put in your what?
in your mouth.
In your mouth.
I get
And then what we'll see in humans especially is at a certain age when we start to become exposed to antigens, foreign substances, that we typically haven't been in our lives, our tonsils are going to become swollen. Because what do we see inside this lymphatic tissue? Well, we see all the players that are going to help protect us from foreign invaders. So when we talk about lymphoid cells and lymphatic tissue, we're talking about the guys that I said we'd talk about later. Well, they're back again, the lymphocytes. So T cells and B cells, remember those guys? These guys are going to hang out in the pinball machine. And they're going to hang out on reticular connective tissue. Remember way back when you learned tissues? And you looked at reticular connective tissue? What did it have a lot of?
There was a fiber.
What kind of fibers? Reticular fibers. And hopefully your Anatomy 1 teacher described reticular fibers to you as kind of like sticky, fine, sticky little spider webs. The cells in this lymphatic tissue, lymphatic cells, T cells, B cells, are sort of stuck to that little spider web reticular fiber mesh. A lot of spaces between that reticular fiber, right? What's passing through the spaces? Fluid, the fluid that you absorbed in the capillary beds from the lymphatic system. Say you have a nasty little creature that has invaded your body and then begins to get into your fluids. Say you have, and I'm pointing at you because you just blew your nose. Say you have a virus. By the way, most of your colds and flus are all caused by what? Viruses. Nasty little critters. They can replicate themselves at a very fast rate, and they have a very high mutation rate. So most of the time when you get sick, it's a virus. And when they start to multiply and get in through your body, using your cells as hostages to make them, they're eventually going to start to get into your what? Into your lymphatic system, into the fluids that are going to pass by through these lymphatic tissues. And eventually someone might bang into, as we pass through the pinball machine, that is the lymphatic system, one of these lymphocytes. When we discuss the immune system, we'll see that these lymphocytes, once they recognize something as foreign, are going to go into attack mode. Remember my swollen tonsils? Why did they get swollen? How do they fight? Exactly, they increase in number. So once one is stimulated and told, hey, there's something foreign in those fluids, I know what it is, it's time to fight, they're going to start to increase in number. They're going to start to proliferate. And that's what happens when sometimes a lymph node gets swollen, because it is filled with those cells that are on the attack. Okay? So in lymphoid tissue, we find reticular connective tissue. We find the cells, the important players in an immune response, which we're going to talk about in chapter 21. And we see a series of compartments. Remember when you talked about spongy bone way back in first semester? What was the name of the structures in spongy bone? We see that same one again, trabeculae, right? We see that little infoldings of tissue are going to create little compartments. And the flow of lymph fluid is going to be only in one direction. What's going to help keep it going in one direction? Same thing that kept it going in one direction in the venous system. What? Well, pressure, pump, but what else? Little valves. So again, very similar in structure to the venous system. as we go through our travels, we're going to come along a pinball machine. This is a lymph node. And fluid is going to flow in only in one direction through the afferent lymphatic vessels. Then it gets bounced around in the pinball machine. Do you see why I'm calling it a pinball machine? Because it'll come in and bang against a wall and maybe get stuck in that compartment for a few minutes and then bang around down here and get stuck down here. It hangs out longer there, and there's more chance for what to happen? If I'm banging into stuff and there's a virus in me, eventually I might bang into what? Somebody that's going to recognize me as foreign. If there's nothing in the fluid, that's great. But if there's something there, it gives us a higher chance for our cells to recognize there's something there. Eventually, once I've bounced around in there for a little while and we see different areas where I might get caught up, created by the trabeculae, we have little central regions called the medulla inside these little trabeculae. We also see the cortex, outside, inside. We saw that when we talked about the adrenals. We see that here in the lymph nodes also. When you look at them under the microscope, you'll see those different areas as well.
So, medulla is like
In the middle, exactly. And you see it in these little central regions. So you'll see it in central regions. In the cortex, you'll see that around the edges. And again, all these areas are filled with reticular connective tissue and filled with lymphocytes waiting for someone to come by. I can only leave the exit tubes. And what do we call those? Efferent or efferent. So I can only come in the afferent and I can only leave through the efferent. Some of the different larger groups of lymphatic tissue. So you should know the structure of a lymph node, basically the description that's in the textbook. Only goes in afferent, only leaves efferent. We have some larger groups of lymphatic tissue. We call them lymphoid organs. So the tonsils, the thymus. The thymus sits on top of the heart. The thymus, as you get older, is going to get smaller and smaller, because the thymus's job, and I think I might have mentioned this when we talked about the endocrine system, what was the thymus's job?
Thymus will produce a hormone that will trigger lymphocyte.
Lymphocyte do what? To do T cell maturation. Maturation. Okay? So this, I think I mentioned this, the thymus I always call T cell kindergarten. You're going to see that in chapter 21. Because this is where the thymus is where T cells will go to become what we call immunocompetent. And that's a fancy way of saying the T cells will be able to recognize foreign substances. So that's where they learn what self-antigens are and what non-self is. Then the lymphocytes will go and hang out in a lymph node somewhere. Once we've trained everybody, we don't really need the training facility as much. So as you get older, your thymus gets smaller and smaller because you already have cells in place in your lymph nodes. The spleen, also a very large lymphoid organ. And then tons and tons of patches of lymphoid tissue in where? Your intestines. The Peyer's patches are what they are called. How about your appendix? What's that doing for you? No, it's not. There's actually lymphatic tissue in your appendix as well. Unfortunately, because the way it sits at the beginning of the large intestine is kind of in an awkward place. So things sometimes, as they're traveling into the large intestine, what might they do? Yeah, they might get stuck up in that little appendix, and then they get infected, inflamed, and that's appendicitis, inflammation of your appendix.
So why
Spleens don't typically do that unless there's some kind of trauma. So the spleen is in an awkward place.
You mean physical trauma? Or-
Physical trauma, typically.
Oh, really?
Yeah. So you might have some sort of internal problems with blood formation and hemolysis that might cause problems with your spleen as well. But usually it's some sort of physical trauma.
Now, generally, with people who have mono, they, don't they usually warn you to avoid a lot of direct contact? Because is your spleen
It tends,
enlarged because it's lymphatic tissue?
correct. And again, it's in an awkward place, and it's sort of out there, kind of like your kidneys. All right, I will give you a break and not finish this chapter, but we will pick up with the mucosa-associated lymphoid tissue on Tuesday of next week.
Question?
Yes, dear.